He mihi mahana, kia koutou. Welcome everybody. I'm John Adams, the Associate Dean of Student Affairs at the Dunedin School of Medicine, standing in for the Dean, Professor Barry Taylor, who is ill and unable to be here today, but it's my great pleasure to be able to introduce these two very impressive professors and a student who's also doing some work in this area, working with Dirk. So Dirk de Ridder, who is the Neurological Foundation Chair in Neurosurgery, has been doing some wonderful work with brains and neuromodulation and the circuits in the brain and the impact on various illnesses, including addiction, which is the subject of today's talk. And Professor Paul Glue, Hazel Buckland Chair in Psychological Medicine and Head of the Department of Psychological Medicine, who is a very eminent psychopharmacologist and very interested in the biological basis of all of these conditions, and especially addiction. I've forgotten your first name. Sook Ling Leong, who is working with Dirk de Ridder, is going to also present to us today, and they are going to very shortly assuage my craving for new knowledge, which may be an addiction, and perhaps they're going to tell us about that. And just to start things off, one of the our eminent psychoanalytic theorists, Carl Jung, said, "Every form of addiction is bad, no matter whether the narcotic be alcohol or morphine or idealism." And Somerset Maugham, "The unfortunate thing about this world is that good habits are so much easier to give up than bad ones." And Mark Twain, I think, says it all. However, quitting smoking is easy. I've done it hundreds of times.
John, thank you very much for that very, very fine introduction. We've had the introductions done already, but I think as this talk goes through, one of the things to reflect on is that this is a lovely example of synergy between departments. Of when you mix a number of disciplines together, the outcomes can be much more than the sum of the parts. So I'm going to start off by giving a brief history of addiction and how we conceptualize it and treat it. So if we were to go back 1,000 years or so, intemperate use of alcohol was really seen as a moral disorder, a sin. And it wasn't until the start of the Industrial Revolution, where you get a primarily rural population moving into cities, where you get alcohol being produced on industrial scales, where suddenly physicians, so this is Benjamin Rush in the States, are looking at heavy alcohol use and thinking that this actually isn't a moral fault, this is a medical problem. And as one of the ways of managing this was to open up big asylums. This was a standard way of dealing with mental health problems. And in this case, they would set up institutions for inebriates. And the image on the slide is the first one set up in the States in Binghamton, New York. There were lots of temperance organizations that were being set up to try and deal with moral and social problems of drinking. Things really then changed in the mid-20th century, where suddenly the medical model started to look at this alcoholism as a chronic disease. And Jelinek, who was a US researcher, was very prominent in this. And then probably the biggest piece of work came from Griffith and Milton Gross in the mid-1970s, where they pulled a lot of research together. So this was not a philosophical approach. This was based on real science and observation of patients, where they came up with the concept of the alcohol dependence syndrome. This is then mutated into the World Health Organization guidelines on drug dependence and has influenced the DSM-5. And the elements that they picked up there, the narrowing of the drinking repertoire and other things, really are sort of key elements, that alcoholism isn't just a single component. There are multiple changes in behavior and thinking. Other concepts, Robert Cloninger, who's a psychiatrist who's still, I think, alive in the States, who'd come up with the idea of type 1 and type 2 alcoholics. So it wasn't that you just had people who met a certain number of criteria, that the type 1s, which he thought were much more common, were primarily people who were drinking to self-medicate. I've got a lot of anxiety, I've got a depression, I'm not coping. Alcohol suddenly takes away a lot of these things. And the type 2s, where they link this with part of an antisocial lifestyle. And these are primarily males who use alcohol as a sort of a very drug-fueled lifestyle. If we look at how the diagnostic criteria in the States have changed, DSM-1 came out in the 1950s and basically said alcoholism is just another feature of antisocial personality disorder. And as DSM-2 came along, they said, well, maybe it is also associated with depression or anxiety or other conditions. DSM-3, 1980, suddenly became a diagnosis in its own right, but it was split into abuse and dependence, and presumably one reflects a less hazardous use than the other, but it was really impossible to say what's the actual dividing line between abuse and dependence. And then DSM-5 finally got rid of the dichotomy of abuse and dependence, came up with a single diagnostic category with severity and specifiers. And this is what the DSM-5 criteria look like. You have 4 domains: impaired control, social impairment, risky use, and pharmacological dependence. You have 11 items within those 4 domains. And the more criteria you meet, the more severe your substance use disorder is. So how do we treat drug and alcohol dependence? Certainly for alcohol, the main approaches are psychological and social. So we have CADS here in Dunedin. We have AA across New Zealand. We have group programs, immersion programs like the Bridge program run by the South Asian Army. We have Nancy Reagan, who quite helpfully in the 1980s said, just say no. For things besides alcohol, we do have other pharmacological strategies. So if you're dependent on opioids, you can get switched to methadone or buprenorphine. Other substitution agents for smoking. Benzodiazepine should work as a substitution for alcohol, but they don't. If you take alcoholics and put them on benzos, they stay on the benzos and continue to drink. And we have some anti-craving medications, we have aversive medications, none of them are particularly effective. So I'd like to come back to the DSM-5 substance use criteria. So if one looked at the top line, where simply the more items that you can tick off, the more severe your substance use disorder is, my feeling is that not all of these are created equal. And the data that Dirk and Sook, Ling are going to present today suggests that actually craving plays a huge role, that you may be able to switch off an enormous amount of both alcohol appetite as well as alcohol consumption by switching off craving. And so, although I'm not suggesting that DSM-6 is going to say craving and nothing else, I think that the idea of balancing out some of these criteria may be an important conceptual change. So what is craving? At its simplest terms, it's a strong urge to consume whatever your substance of choice is. And it's not a unitary phenomenon. So it can have both positive feelings. When I have that glass of wine, it's going to make me feel so relaxed. It could be to overcome negative feelings. I'm feeling anxious, so I need a glass of wine. Or I'm having some withdrawal symptoms first thing when I wake up in the morning, so I need to have a glass of wine just so I can start out the day. These can happen spontaneously. These can happen in the background. But you can also elicit them by internal or external cues. And some of the data you'll see today is when you're showing alcoholics images of people drinking, images of, say, alcoholic beverages, you can see relevant brain areas lighting up, areas to do with craving or salience, and areas to do with reward. So why do we treat addiction? It's prevalent, it's expensive, and it's a social burden. And if we look at prevalence, in the top 3 rows, we've got tobacco and alcohol that are still legal. And we also have illicit drugs, and the dependence on things that are easily available is much, much higher rather than illicit drugs. We have relatively high rates of dependence, depending on what substances we're looking at. So cannabis dependence is relatively uncommon compared with, say, dependence on heroin or cocaine or stimulants. It's expensive. One of the things that we do when we see patients coming into the acute ward where I work is looking at what their substance use entails in terms of financial outlay and how they're managing this. And often it means that either family resources are getting poured into this, or people are having to steal things, do sex work, sell drugs in order to meet their habits. And the numbers when you look at population costs for substance of abuse are just jaw-dropping. It's a major social burden, and these are US data from about 18 years ago. It's looking at the proportion of arrestees who are involved with some sort of crime. These are different New York states. And we see huge association with violent crime, child abuse, theft, property crimes, and drug dealing. So is it curable? It's certainly possible to drive people out. It's certainly possible to look at what may be driving people to drink. And the biggest challenge is not driving people out or stopping their consumption. It's actually managing relapse. And you, again, based on this British study, probably close to 85% of people with existing alcohol use disorders who've dried out will start drinking again at some point. And the three key elements that have been identified are craving. So the craving doesn't necessarily go away even though people are sober, alcohol cues, and stress. And we've taken an approach where if we can look at craving and stress, we can't do away with the TUI billboards or wine advertisements in supermarkets, but we can perhaps manage craving and stress as therapeutic targets. Dirk.
In order to try and develop a treatment for brain-based treatment for addiction, it's important to try and understand, well, how does the brain work, and how can we then modify craving? Can we modify sensitivity to cues, and can we modify a stress response? So from a conceptual point of view, the brain is actually a prediction machine. That's its fundamental function, is to predict what's going to happen. And this is essential once multicellular creatures start moving around in the environment. And in order to do that, in order to make those predictions, those multicellular creatures start using information from previous experiences, which we call memory, so that it can better predict what's going to happen. For example, if you drink a glass of wine, I might feel more relaxed. Or if I'm going to go behind a corner, I might meet something to eat, or might meet a potential partner. And of course, what you predict is based on what is stored in memory, but also on the current context, always related to the self. But ultimately, the fundamental goal of the brain is to reduce inherent uncertainty, which is embedded in a changing environment. And this is, of course, important from a Darwinistic point of view, both for survival and for procreation. So from a conceptual point of view, the brain consists of different modules, and those different modules are connected to each other and interact. It doesn't mean that if one module is active, that the other module is also becoming active. They can be anti-correlated, where if one module is active, the other becomes inactive, which, for example, is normal when we're in a default mode state, which means we're mind wandering, we're resting and digesting. Then when we're thinking about the past and the future, when somebody calls your name or calls fire, something in your brain has to tell you, well, I have to pay attention to this new external input rather than continue to mind wander. And so when the Salience network, which tells you something is behaviorally relevant is happening, becomes activated, then it shuts down the mind wandering default mode network in order that you can pay attention to the external stimulus. That being said, there is also an interaction between those two networks, one which says this is behaviorally relevant, and that has to drive the other network to shut down, and more likely than the other way around. So you have driving networks and networks that are being driven. And of course, this information all has to integrate into another network, which is called the binding network functionally, or the rich club anatomically, where all the information that you are experiencing at the same time becomes integrated into one unified percept. Now, from a practical point of view, there is two very, very important networks in the brain. One which is called the salience network, and the other one which is called the default mode network. The salience network consists of the anterior cingulate and the, which you can see right here, the anterior cingulate, as well as the anterior insula. And basically, the salience network just tells you something behaviorally relevant is happening in the environment. The salience network is also involved in craving and overlaps partially with the central components of the sympathetic nervous system, which of course is the system that is involved in fight, flight, feed, and fornicate responses. Basically, the sympathetic nervous system is what allows you to respond to a stimulus in the external environment. And therefore, it also drives your attention towards what is happening in the environment. So on the one hand, you've got the salience network. On the other hand, you've got the default mode network, and this is based on a neurosynth meta-analysis of 627 studies, whereas the salience network was on a smaller number, meta-analysis of a smaller number of studies. But so the default mode network involves predominantly the pre-general anterior cingulate and the posterior cingulate in the medial part of the brain, is a self-referential network. So every stimulus that occurs internally or externally has to be related to yourself and referred to the self, and this is one of the main functions of the default mode network. And this is involved more in liking, as we will see later, and overlaps with the parasympathetic system, which of course is a system that helps you to rest, restore yourself, and to digest. So when you're not having to pay attention to the outside world and you start mind wandering, then basically your default mode network becomes active. And the default mode is linked to the memory network, which of course you need in order to be able to start mind wandering. Now, the switch between the salience network and the default mode is most likely the area where they overlap, which is in the posterior cingulate area, as you can see right here. So from a practical point of view, those two very important brain networks interact, where if one is up, the other one is down, and the other way around. So the salience network, to put it very simple, says something is behaviorally relevant, and in general tells you that you need to acquire more information in order to pay more detail to the information that might be relevant to the current situation. So what happens is when the salience network is active, you get an urge for action, irrespective of which kind of action, and it will also create this sympathetic activation response, so the 4 Fs, and it will reset your reference in order to be able to extract more information from the environment. So basically your gain in your brain will go down, so that it's more easy to detect whatever stimuli occur in the environment. Now, this resetting of this gain, which is also called allostasis in contrast to homeostasis, also involved actually the default mode network, which basically tells you all is quiet at the battlefront. I can sit and rest and digest, and I've got enough stimuli, basically also suggesting that you can activate your parasympathetic system and that you already have enough information to control the current environment, and therefore it can suppress any further input. So whereas on the one hand, the salience network will decrease your gain so you can extract more information from the environment, and it will drive you to look for more information. The default mode will do the opposite. it will make it possible for you to rest and digest, and to actually to suppress further input, which would be irrelevant anyway, because you already know how to control the environment. So if you summarize that in a very simple model, what you see is that the area in the brain, and this is a little bit phrenological because it's actually a network, but the hub of that network is in the rostral anterior cingulate, and in a meta-analysis, as you can see here, of close to 100 studies, you see that this area in the rostral anterior cingulate tells you there is uncertainty. Uncertainty meaning you don't have enough information about the environment to make a next decision. So if you don't have enough information for what is happening or occurring in the environment, what you will do is it will urge you for an action to go and look for missing information, and this is then controlled by a second hub very closely related in the dorsal part of the anterior cingulate. Now then, that will drive you to actively go and explore the environment for more information, and if you have found the missing information, that will subsequently activate the medial, the pre-general anterior cingulate, which is related to hedonia, pleasure. So once your brain extracts the missing information and tells, I've got all the information I need now in order to continue, then the yellow area, as you can see from the meta-analysis here, will become activated, and that will create a feeling of pleasure. Now, if, and on that moment, you will suppress further input and go into a parasympathetic resting state, and basically the item that solved the missing input will then be stored into memory, so you can use it next time once you are in the same context and the same situation. Now, if you have enough information, then basically you will inhibit action, and that occurs in the SMA area, as you can see from this meta-analysis. So that will shut down further exploring of the environment and will help you to rest and digest. If, however, you do not get the missing information enough, you will basically go into a kind of a vicious circle where you will continue to activate this green part, the dorsal part of the anterior cingulate, which will drive you to keep on looking for missing information. And this keeping on looking for missing information phenomenologically is expressed as craving. It drives you, it's an urge to look for whatever is missing, whether that is food, whether that is sex, whether that is work, whether that is gambling, it doesn't really matter. It's a non-specific craving circuitry that involves this part of this dorsal to rostral part of the anterior cingulate. So basically in the brain, everything is controlled by a balance between salience for external, predominantly external stimuli, and so what is behaviorally relevant and what is behaviorally irrelevant. And this balance is in itself associated with the sympathetic nervous system and the attentional networks, whereas a default mode network will suppress further input, is associated with parasympathetic activity and memory-related activity. Now, this balance is controlled most likely by our self-referential network that will tell you, I need more, or I have enough external information. So what does this have to do with addiction? Well, addiction in itself is can be seen as a disease of the brain, just like you can use PET scans in order to look at metabolism in the heart. You can use PET scans, fMRIs, EEGs to look at brain activity related to addiction. So addiction is a brain disease, just like other problems might be heart or other diseases. So we've tried to elucidate what is a non-specific addiction circuitry in the brain, which involves, unsurprisingly, part of the default mode and part of the salience network, which are normally anti-correlated. But what in addiction might be the problem is that they're out of balance. So when input and suppression of input are in balance, depending on the context and depending on the requirements, actually in addiction, what you see is that there is a shift where everything becomes salient related to the specific part of what you're addicted to. So everything which is related, for example, to alcohol, everything which is related to sex, everything which is related to cocaine, whatever product you're addicted to becomes very salient, and you almost never go to this rest and digest state where you can relax and sit back. So addiction can actually be seen as an imbalance between those two important networks in the brain. Now, because these networks have to communicate in the brain, the way different networks in the brain communicate is by being anti-synchronized or by being synchronized. And normally, those two areas, the default and the salience, are, as I mentioned, anti-synchronized, which you can see in this picture, where the blue-green areas are basically the default mode, and they're anti-correlated to the yellowish areas, where you see the anterior insula and the anterior cingulate involved in an anti-correlated activity to each other. Now, what you see in addiction is that actually those areas between the posterior cingulate and the pre-general anterior cingulate, two areas of the default mode, actually become synchronized with the dorsal part of the anterior cingulate. So your brain is saying, well, I have enough, but I want more at the same time. And so if it doesn't know what to do, it will go for safety and actually try to get more of the same stimulus. Now, we know that in addiction, people get pleasure, at least short-term pleasure, from what they, from the substance of abuse, whether it's alcohol, whether it's cocaine, whether it's heroin, doesn't matter. And when we look at the correlation analysis between the pleasure they extract, the people extract from the stimulus, in this case, this was food, to the salience that they attach to the food, then this occurs in everybody, whether you're addicted or non-addicted. For everybody in the audience, basically, when you like somebody, you attach behavioral relevance to it, or when something is behaviorally relevant, you might like it. Furthermore, allostasis or reference resetting is something we all do. When we eat, basically what's going to happen is you're hungry, you eat, and progressively your brain tells you, well, I'm getting all the energy that I need, so you will basically get less and less pleasure from eating, and you'll get to satiety. And if you continue eating, actually you get the opposite, and you start feeling nauseous. So this allostasis will drive craving in all of us. However, when we look specifically at food-addicted people, what happens is that the behavioral relevance, the salience, drives the craving, and not directly, but indirectly via reference resetting. So what seems to occur in the brain of an addicted person is that the behavioral relevance attached to the stimulus, whether that is cocaine, alcohol, food, sex, it doesn't really matter, that will cause a reference resetting, and this reference resetting will drive the craving. But then the question is, of course, where in the brain does that happen? Because if we know where you're resetting your reference, where the craving is controlled, then we might use that as a target for stimulation. So if you look at where it occurs, basically it's the PCC, the posterior cingulate, this part of the default mode, the self-referential setting that drives predominantly the PCC drives the anterior cingulate to say, I want more, and the pre-general anterior cingulate say, I have enough, but in a similar way, and that might be one of the causes of the craving problem. So where should we target? What should we use as a target in order to implant electrodes or non-invasively stimulate? So what we ideally, because as Paul has said, what happens in addiction is that you can treat addiction. Unfortunately, most of the people, 75 to 85%, will relapse. How can we prevent this relapse? Well, relapse occurs because of craving, because of cues, and because of stress. Can we find one target that is involved in the circuits for those three phenomena? Craving, based on a meta-analysis, is correlated to activity actually in the rostral part of the anterior cingulate, and this is for all kinds of substances of abuse. Here more related to alcohol and more to food. So basically, which is of course, as you might remember, the central hub of the sympathetic nervous system and is the central hub of the salience network. And so craving could be targeted there, but craving could also be targeted in the nucleus accumbens, which is part of your reward system that might give you a feeling of reward when you or predicts that your craving will be reduced once you take the substance of abuse. Now, if you look at alcohol-related images, then you activate not just this part that is involved in craving, but also the self-referential network. So both the salience network as well as the default mode network. Now, when you then look at a lot of different stimuli, whether it's cannabis, cocaine, heroin, nicotine, sex, gambling, doesn't really matter. Any kind of stimulus will actually create a response in the rostral dorsal part of the anterior cingulate, as you can see here, and as well as the nucleus accumbens. So basically, two areas that we can target based on craving and based on cues. Now, when you then look at stress, where is stress? What's the stress network in our brain? Unsurprisingly, it's actually overlapping with the sympathetic nervous system, which is the one that gives you the drive. And there you see that it is predominantly this rostral part of the anterior cingulate, but not the nucleus accumbens, which is not involved. So basically, in summary, craving, cues, alcohol-related cues, and stress, the three main causes for relapse, overlap in one target, and that is the rostral dorsal part of the anterior cingulate, which would be therefore an ideal target to use by non-invasive and invasive stimulation. And to be more specific, it's the little blue spot, which is where responders and non-responders actually are different. So in order to, now that we've got a target, Sooklyn will actually now explain you how we try in a non-invasive and invasive way, try to modulate this, this unique target for alcohol addiction.
Activated at either 3 days or 17 days post-operation. What followed was 12 weeks of optimization of the stimulation, where we tried to reduce their craving, which was measured on a 10-point scale, where 0 was no craving at all and 10 was I'm craving the most ever. Assessments were at 12 weeks, 6 months, and 12 months follow-up. So 8 participants completed all protocol-related activities. The primary endpoint of the study was alcohol craving, and the secondary endpoints were mood and adverse effects. So as you can see in this panel here, as a group, there was a huge decrease in craving as well as standard drinks per day. When you compare at pre-stimulation to healthy controls, participants had an increased beta activity in the dorsal anterior cingulate cortex. When you compare post-stimulation to pre-stimulation, there was a decrease in beta activity in the DACC. Although you see this drastic decrease in craving and standard drinks, 2 participants relapsed at 12 months follow-up. Also, most participants continued drinking throughout the study. So when we asked why that might happen, they said, oh, we had more control of the drinking. So they could stop when they wanted to. Also, when asked, they attributed the reason for drinking to habit, suggesting that this treatment may actually control craving but not habitual overconsumption of alcohol. So these are the secondary outcomes of the study. As expected, there was a significant decrease in craving as measured by the validated alcohol craving questionnaire now. We also found that there was a significant decrease in depression, obsession, and compulsive score. However, we did not find any changes in state or trait anxiety, suggesting that this treatment may benefit those who were drinking to reduce depression or obsessive or compulsive behavior, but not for those who drink to reduce anxiety. These are the adverse events of the study. I'm not going to read them out, but what I'm going to say is that none of these adverse events were related to the stimulation of the study. They were related to the surgery. So the next study I'm going to describe is a non-invasive study aimed at exploring the effect of high-definition transcranial pink noise stimulation of the DACC on food craving. So with traditional saline Sook electrodes, we are stimulating a very large area of the cortical region, and 50% of the current is being deflected by the skull. With HD or high definition electrodes, you get to stimulate a more precise area of the cortical region. So a note on pink noise. Pink noise is a signal where the power is inversely proportional to the frequency. So pink noise resembles the naturally occurring signals in the self-organization of brain networks. In this study, we recruited 16 women. They all had a BMI of 30 or more, and they scored 3 or more on the Yale Food Addiction Scale, or YFAS. The YFAS is a validated measure of food addiction, similar to the DSM-5 for substance addiction. The primary outcome was measured using a craving questionnaire, which was validated, the FCQS. The secondary outcome of the study was brain activity assessed using EEGs. So the study was a 6-week randomized double-blind parallel study. We chose the parallel instead of the crossover design because we did not know how long the effect of HD-TPNS will last. At baseline, participants completed the FCQS and we collected EEG data. All participants had 6 sessions of HD-TPNS or placebo over a period of 2 weeks. In the intervention group received 1 mA of 1 milliamp of stimulation for 20 minutes. There was also a 60-second REM-up period. So during this 60 seconds, you feel a little of itching under the electrodes on your scalp. And for the next 20 minutes, you actually do not feel any sensation on your scalp. So to replicate that itching sensation, the placebo group also had a 60-second REM-up period, but then the stimulator was turned off after that. So there were no adverse effects aside from that slight itching sensation because of the REM-up session. And when we asked participants post-intervention what did they think they received, all of them replied real treatment, suggesting that the blinding procedure actually worked. So these are the results of the study. an ANCOA analysis showed that there was a significant decrease in an intense desire to eat post-stimulation in the treatment group compared to the placebo group. Also, when comparing post to pre-stimulation, you see a decrease in beta activity in the dorsal anterior cingulate cortex. So the final study I'm going to describe used an operant conditioning technique called infraslow neurofeedback to treat food addiction. So instead of targeting the dorsal anterior cingulate cortex, which is part of the Salience network, we targeted the posterior cingulate cortex, which is part of the default mode network. Like Dirk said, theoretically, these two areas are anti-correlated. So an increase in PCC or a decrease in DACC activity may correlate to a decrease in craving. A note on infraslow. Infraslow has a frequency of less than 0.1. Infraslow is a communication wave, so it connects the two networks. Infraslow signals are also carrier waves, which allows higher information waves such as the beta wave to nest on top onto it. So for neurofeedback, firstly, we acquire whole brain EEG data using an amplifier and an EEG cap. A program quantifies ISF infraslow activity from the PCC, and if it reaches a certain threshold, the program produces a sound as a reward, as a feedback. That sound strengthens ISF activity in the PCC, and this happens in a loop. In our study, the treatment was for 20 minutes, and in the placebo group, the reward sound was played at random. So the aims of the study was to examine whether ISF-NF of the PCC is technically feasible and can result in measurable changes in brain activity. 21 women participated in the study. They all had a BMI of 25 or more and scored more than 3 on the Yale Food Addiction Scale. The primary outcome of this study was EEG brain activity, and secondary outcomes were craving, measured using the FCQS, and well-being measured using the WHO-5 well-being scale. So just like the previous study, it was a 6-week randomized double-blind parallel study. At baseline, participants completed the questionnaires and we collected EEG data. All participants had 6 sessions of ISF-NF or placebo over a 2-week period. Post-intervention, which is 2 days after the last stimulation, participants completed all baseline assessments again. So these are the primary outcome of the study, which is brain activity. In panels A, B, and C, you see that there is an increase in infraslow activity post-treatment in the posterior cingulate cortex in the treatment group compared to the placebo group. Results also showed that there was an increase in beta infraslow nesting post-stimulation in the treatment group compared to the placebo group. These are some of the secondary results of the secondary measures of the study. So post-stimulation, there was a significant decrease in the different craving measures. And we also found that there was an increase in subjective well-being in the treatment group compared to the placebo group post-intervention. So this last panel here, this analysis was done only in the treatment group. According to the WHO-5 well-being scale, those who have a score of less than 50 have poorer subjective well-being, and those who have a score of more than 50 has good well-being. So what we did was we divided the groups into below 50 and above 50. So what you see is that those who had a well-being score of below 50 at baseline significantly benefited from the treatment compared to those who had a well-being of above 50. So in conclusion, addiction is a biological psychiatric disorder and it has a great impact not only on the individual but on society. Its main treatment problem is the high prevalence of relapse, which is caused by craving, cues, and stress. Targeting the RDACC as a common hub in the three involved brain circuits seems logical, and the treatment can be performed by different non-invasive and invasive neuromodulation. Treatment of addiction requires multidisciplinary approach, and the studies that I have just described were the first studies to use this approach, and they have promising results for pilot studies, and they warrant further investigation in larger clinical trials. Thank you.
Wonderful. I'm sure that there are a raft of thoughts and questions, and Georgia has a microphone here in a cube that she will throw to anybody who wants to talk or ask a question so that we get this on tape. Could I set the ball rolling by just asking, are there effects when you do the stimulation on motivation more generally? If you interrupt craving, does it impact on motivation for other tasks as well, given that what I understood you said that the process was generic in terms of substance or task?
This is a very good question, and we have not looked at it. But of course, this target, the anterior cingulate, has been used in psychosurgery in the 40s and the 50s for a long time. And it is a target that is involved or that can be used not just for alcohol addiction, but is being used also for other pathologies. So from a theoretical perspective, I would say yes. However, if you lesion the rostral part of the anterior cingulate, motivation in general does not seem to be altered psychologically. What is altered, however, is sustained attention. So by suppressing the activity, it becomes more difficult to long-term concentrate or focus on one thing, which is, of course, also the goal of the treatment, because patients with addiction have the opposite, is that they can only focus on one thing, that's the substance of abuse. But considering, even though we haven't looked at it in a clinical group, the idea is that, yes, it will decrease motivation. So, for example, if people are on cocaine and you show them erotic movies, they will be less motivated to continue watching those movies than if they're not on cocaine, because the circuit is already hijacked by the cocaine. And so another biological stimulus will not motivate them as much as you would expect, or as in controls in which the circuit is not hijacked yet.
Thank you. Questions?
Just on that, on the same sort of thought there, with the activation of the sympathetic nervous system, is that, I mean, you talk about the fight and flight response, is that at all affected? Let's say if something sudden were to happen that was to require your attention in your, flight, for example, have you seen any effects in there after changing ACC?
That's a good question, and this is part of ongoing research now that Sook is performing, where together with Luke Wilson from internal medicine and Tyson, who's also here present in the room, where we want to see how does the sympathetic and the parasympathetic system, how can we influence them in healthy controls. That being said, most neuromodulation techniques are interesting in that they seem to work especially on once you deviate from the norm. So if you're a healthy control, actually it's way more difficult. And we tried to stimulate the anterior cingulate part in healthy controls, and phenomenologically, any psychological measure, any behavioral measure that we looked at, we couldn't find any differences. But we didn't look at autonomic nervous system per se, which is what we're currently looking at, partly to address the question that you're posing. So the hypothesis might be probably not, but if you're in a constant hyper sympathetic drive, then we might bring it back to the norm. If you're in the norm, it becomes difficult for two reasons. Maybe there is a ceiling effect, so we can't measure it. There might be differences, but we can't measure it. But if we can't measure it, it might also not be clinically relevant.
Right.
Just more of a technical question about the electrodes itself. So if you're putting a voltage over the area in question, are you trying to increase or decrease the amount of neuronal activity in that region? How does that work?
And which of the studies are you talking about? The non-invasive or the invasive or the neurofeedback? Because in neurofeedback we don't apply any current. We measure voltages, but we don't act with the external or the internal. It is. That's a very good question, and it's strange that we've been using, for example, implants for over 40 years, and we still have not a clue what we're doing. What we know is that if you use high frequencies in tonic mode, you probably induce an electrophysiological silence in the area that you target. So basically, the cells can't follow the current that you inject. With lower frequencies, partially you can drive cells to follow the rhythm, but if you then increase the frequency, they just can't follow. And you create an electrophysiological silence with a burst of activity intermittently. Now, it's exactly these bursts that drive oscillations, so that might actually induce a lower frequency. Now, with burst stimulation, the ones that we used for in the addiction study with the implants, instead of blocking activity, you're actually driving activity. That's what we assume, that you're driving activity to follow the frequency that you're injecting. And so what we've seen, which we didn't report here, is that of the two failures, they were actually being stimulated at 10 hertz burst mode, which is a little bit too high because the natural frequency of the target area is a little bit lower, in between 4 and 7 hertz. The ones that responded well were actually being stimulated at their natural occurring frequency, whereas, as you've seen on the images, the oscillation frequency in those patients had gone up to beta frequency. So instead of the normal 4 to 7 hertz, they're actually running at 12 to 30 hertz. So this overactivity is also what we reduced by stimulation, at least in amplitude. So to answer your question, when we, depending on the frequency and the stimulation design, you either block activity. So whether you do that or you do a cingulotomy, you make a lesion, is actually the same. The problem with that is that the effect when you create a lesion is usually only transient for about 6 months, and after 6 months the effect wears off. This is why we looked at 1 year, because we know 1 year is, if you have still an effect after 1 year, that is better than what you would expect with a lesion. So yeah, we're driving it, but that is because of the frequency that we use and the stimulation design.
Ladies and gentlemen, we're at time, and we have been very privileged, I think, to hear of this groundbreaking research happening in the Dunedin School of Medicine, and we thank you three very, very much for your work and for sharing this with us. Thank you very much indeed.